Hello, nurses. This is Lisa. I have a podcast today about Chapter 24, Self-Concept and Sexuality. So our learning objectives today are to discuss factors that influence self-concept, identity, body image, and role performance, describe the components of self-concept as each relates to Erikson's developmental stages, identify stressors that affect self-concept, self-esteem, and sexuality, identify methods to approach sexual assessment discussions, recognize indicators of sexual abuse and the nurse's legal obligations, utilize the nursing process to promote a client's self-concept and sexual health, and to identify a method to manage sexual harassment in the workplace. So before we get started, I just want to mention that we put these two topics together, sexuality and self-concept, because they are so linked. It can be very difficult to pull them apart. And so when we think about self-concept, that really is just your view of who you are. It directly affects your self-esteem and how you feel about yourself. Self-concept and sexuality include a complex mixture of unconscious and conscious thoughts, attitudes, and perceptions. What you think and feel about yourself affect the way in which you care for yourself physically and emotionally. It also influences the way in which you care for others. As a nurse, you care for patients who face a variety of health problems that threaten their self-esteem and their sexuality. Help your patients adjust to alterations in self-concept and sexuality to promote successful coping. Identity includes the sense of a person over time and in different situations. Identity is formed in childhood as children learn culturally acceptable values, behaviors, and roles through identification and modeling. Part of this identity includes gender awareness and sexual identity. Role performance includes roles such as parent, supervisor, close friend, child. Society roles often impact how we perceive role performance. Having difficulty living up to perceived societal or cultural standards can affect self-concept and self-esteem. Self-esteem is positive when one feels capable, worthwhile, and competent. A situational crisis, such as a hospitalization, often temporarily affects one's self-esteem. Your acceptance of a patient as an individual with worth and dignity helps to maintain and improve the patient's self-esteem. So, when we're talking about stressors that can affect self-concept, it is good to start thinking in terms of Erikson's stages. And there's a really excellent table in this chapter on page 626, Erikson's developmental tasks and impact on self-concept and sexuality. So it's going to be very helpful for you to review Erikson's stages. These stressors can be real or perceived. They can challenge a person's adaptive capabilities. So another chart that you should look at in your textbook is on page 628, and this is common stressors that influence self-concept and so or self-esteem. And so body image stressors would be someone who has a stroke, or colostomy, urostomy, any kind of ostomy, eating disorder, arthritis, incontinence, obesity, multiple sclerosis, amputation, scarring, aging, pregnancy, mastectomy, rape, or assault. Identity, common stressors that influence identity, job loss, change in marital status, abuse or neglect, dependency on others, sexual patterns or concerns, repeated failures, societal attitudes, and conflict. Role performance would be an inability to balance career and family, physical, emotional, or cognitive deficits, loss of satisfying role, transition from school to work setting, promotion or demotion, changing work environment, empty nest syndrome, assuming responsibility for an aging parent. And then when we look at page 630, I know I'm kind of moving into the next. We're going to leave that, but keep that box 24.3, 630. You're going to need to review that. When we, remember I said we need to review Erickson's theory because that helps us know what we expect the patient to accomplish, and when they can't accomplish that, that can become a stressor, in fact, affect self-esteem and self-worth. We know that inability to provide for oneself and one's family is a major blow to self-esteem. But also think about what the patient is experiencing when they have a health crisis and how the physiological changes affect the psychological changes. And we're going to talk more about that in class. Remembering that self-esteem is positive when a person feels capable and worthwhile and competent. When there's a physical change or an illness, that can definitely alter somebody's body image, identity, role performance. And we're going to talk more about that in class. So let me go back to sexuality, older adults, back to that box 24.3 on 630, and promoting self-concept, self-esteem, and sexuality in the older adult. So as we remember, with aging comes expected physical change, including the increase of chronic disease. And so when we're discussing self-concept, esteem, or sexuality issues, it's important with older people that they understand the normal changes of aging and what to expect. Making sure they have coping mechanisms to deal with the changes. And if they don't have coping mechanisms, how can we help them get some coping mechanisms? Encourage reminiscence and making sure that they still know they are worthwhile, even if it's not in the same way they were when they were younger. And all that non-judgmental therapeutic communication is going to definitely come into play at that point. Okay, so little change of subject, and I'm sorry, I just noticed there's no title on this slide, but this is a video I would really like you to watch. This is a video about care of the trans and gender nonconforming patient, and they really have issues with self-esteem as a group and self-concept because they're what they consider their role and their they're thinking about what they think about themselves is different from what society thinks about them. And so there's there can be a big crisis there, and definitely can affect the self-esteem and self-concept of somebody who is LGBT, and we need to be sensitive to that issue with patients. And again, non-judgmental. Watch your communication. If you nonverbal as well as verbal, ask their preferences. What do they prefer to be called? And if you watch this video, it's going to give you kind of a really good example of what not to do, and then an example of what to do. So moving on to sexuality, it's a broad term that refers to all aspects of being sexual. It is part of a person, and it is important for overall health. Sexuality includes a person's thoughts and feelings about the body, a sense of femaleness or maleness, romantic and erotic attachment toward others, and attitudes toward sexual functioning. Our sexual health is based on our ability to form healthy relationships with others. Genitals are the primary identifier of gender, definitely at birth, and remembering that biologic gender, male is XY chromosome, female is XX. Gender or sexuality is the inner sense of being male or female. And it can be reflected in the gender role, which is the way you present yourself, male or female, and this may not be the same as the biologic identity. When we talk about sexual preference, there's some definitions here, and one is heterosexual, which is partnering with the opposite sex. Homosexual is partnering with the same sex. Bisexual could be both the same and or opposite sex. Transsexual is when the biological genitalia and the sexual identity differ. So this may also include surgical sexual changes. And transvestites assume or adapt dress and behavior of the opposite sex, privately or openly. And so it's really good to think ahead of time about how you can address sexuality with patients who have the same or different sexuality, sexual orientation as you do, and trying to be comfortable talking about that topic can be very difficult, and it comes with practice. So when we are going to talk with people about sexuality, we have kind of a little tool that we can use, and this is on page 634 for you, the Plicit model. And the first is permission to discuss sexuality. It can be a very difficult subject for people to discuss, especially if the nurse is acting uncomfortable. We have to remember we are role models, and we can control our attitudes and biases and prejudices by being knowledgeable, being comfortable with our own feelings, with our need to accept the patient, providing a positive matter-of-fact approach. That makes it so much easier to talk about. Being aware of verbal and nonverbal communication, and being knowledgeable about a person's sexuality or alterations in their sexual health. So when we're asking permission, it definitely can help to know, to be aware of all that information. So we have P, permission. The LI is limited information. So sometimes, well, I shouldn't say sometimes, very often patients have wrong information, or the information they think they know is not correct. And so we can, as nurses, correct any myths or uninformed opinions that people have. S is specific suggestions, only when the nurse is clear about the problem. So the nurse can make suggestions in this arena, and but you need to make sure that you know what the problem is, be 100% sure. And then we can recommend therapy with a professional. There are there is a actual sexual therapist in Saginaw area. So we do have somebody at least a little bit close by who does that for a living and is an expert in that area. So I want to talk about behaviors when people have an altered self-concept, and it could be sexuality is wrapped up into that. And if you look at these behaviors, they're all pretty, if you think about somebody who's really depressed, or that they have some type of altered self-concept, slumped posture, they're unkempt, they're overly apologetic, they're withdrawn, they can be very passive, or maybe sometimes they are angry for seemingly no reason. They're negative about themselves, and you can kind of picture that person. So we're always observing those behaviors in a patient, and things that we can do, make sure in addition to these behaviors, is know the patient's cultural background, determine the patient's feelings and perceptions about changes due to their health issues, whether it's physical, self-esteem, or their role status. Assess the quality of patients' relationships and social support, and assess their coping skills, and what are the patient's expectations from their support systems. Okay, so we talked about older adult considerations, and I did want to discuss some little bit more specifics here when we're talking about self-concept and self-esteem issues, making sure that we are exploring the person's resources, strengths, support, whether the support is family, friends, neighbors, community, is important when we're creating a plan for that older adult. And then asking what the patient's expectations are from these in this plan and these interventions, because it gives us a really good chance to talk about what the patient's goals are. Because remember, your goals might be different from the patient's goals. And when we're talking about possible sexual dysfunction for men, erectile dysfunction, impotence, ejaculation problems as people age, and then women can have inhibited sexual desire, the inability to have an orgasm or painful intercourse, which is called dyspareunia. The decrease in hormones in females as they age can increase vaginal dryness, and that's very often what causes that painful intercourse. And then talking about what is their goal? Do they want to enjoy sex again? Do they want to, make sure that their goals and your goals to help them and support them are on the same page. Okay, so I want to also talk about sexual abuse here, and that box 24-4 that is on the slide, which is on page Box 24.4 is on page 631, signs and symptoms that may indicate current sexual abuse or history of. Very many of these signs and symptoms are similar to just physical abuse, but we have some additional ones, which would be unexplained vaginal or anal bleeding or soreness, withdrawal. Very often substance abuse is taken on because the person can't cope with what's going on. And obviously, reports of being sexually assaulted would be considered a sign or symptom. And so being alert to those clues, if the abuser is with the person who's being abused, they may be having controlling behaviors, won't leave the victim alone to talk with the healthcare person. We're going to talk more about human trafficking in just a moment. Interview the victim privately. There's a really good question. Have you or are you concerned for your personal safety? Are you in a relationship where someone is hurting you? Have you ever been forced to have sex against your will? Are some good questions to get you started. Remember, we are legally required to report any type of abuse. And usually if we're in a facility, we can report to social worker. Sometimes we are actually calling the police in ourselves, depending on what the policy is in your facility. And it's important, remember our number one job is patient safety. And so we have to maintain that patient safety as much as possible, even when they're in the healthcare area. Some facilities will have a specific nurse or social worker who will help with this piece. And the nurses are called sexual assault nurse examiners. So they are, abbreviate that as SANE, SANE. So I'm going to bring up a different screen. So this slide is a way to measure if we think somebody is being sexually trafficked. And so just 4 simple questions that can help us, if we suspect that we are having somebody who has this issue. Healthcare people are often the only other people that they interact with. And so nurses are going to spend the most time in healthcare with this patient. And if we are worried that someone is being trafficked and used for sex and being given drugs, here are some questions we can ask. And of course, we try to ask them away from anybody else. If you are worried that the abuser or the person who is doing the trafficking is going to be returning to the area, you may have to ask some quick yes or no questions. And so the first one on this screen, it's not uncommon for young people to stay in work situations that are risky or even dangerous because they have no other options. Have you ever worked or done other things in a place that made you feel scared or unsafe? Sometimes people are prevented from leaving an unfair or unsafe work situation by their employers. Have you ever been afraid to leave or quit a work situation due to fears of violence or threats of harm to yourself or your family? The third question. Sometimes young people who are homeless or who have difficulties with their families have few options to survive or fulfill their basic needs such as food and shelter. Have you ever received anything in exchange for sex, such as a place to stay, food, or money? Sometimes employers don't want people to know about the kind of work they have young employees doing. To protect themselves, they ask their employees to lie about the kind of work they are involved in. Have you ever worked for someone who has asked you to lie while speaking to others about the work you do? So those are pretty lengthy questions, and if you have a short amount of time, you're going to have to cut those down to try to get to those answers for a person. And now these say for youth indicators of human trafficking, but you can ask these to anybody. And of course, we need to notify law enforcement as soon as possible if we suspect trafficking. I want to talk about evaluating our interactions with patients when we're talking about self-concept, self-esteem, or sexuality. And so when we're evaluating this, a lot of it is going to be asking questions. It might not be when we're writing our plan. A lot of what we are going to be looking for are patient reports. We're not always going to see that measurement like we would in other areas, but we can just monitor for changes in the patient's statements about him or herself, asking about how roles have changed over time and the acceptance of those role changes. And we definitely can observe some self-care as well. Are they clean? Did they comb their hair? Did they brush their teeth? Some personal care issues. Last topic for today, I want just to mention sexual harassment as an issue in just about any workplace. Every workplace has a policy for sexual harassment, and you should always look at that, even if you're not having those issues at your work. But sexual harassment is any unwelcomed verbal or physical advance or sexually explicit statement. So, what to do if you are being sexually harassed? You should always confront the harasser and document what the issue was. And that doesn't mean, when we say confront, that doesn't mean you have to get your fists out, but it means you need to tell that person, when you say this type of thing, give an example, it makes me uncomfortable and it is unprofessional and I would like you to stop. And you document that. Okay. The second time it happens, you do the same thing, you document, and then you take it to human resources at that point. If at any point you feel that safety is an issue, you report that right away. Okay, and so if it's happening up to a fourth time, then you can go to the police with that. But usually workplaces take sexual harassment complaints very seriously, especially in healthcare. We have a lot of women working in healthcare, and it's been my experience that it has taken very seriously and dealt with pretty quickly and not left to fester. So just be aware of that. Of course, that could be an issue in just about any workplace. So that is our podcast today for self-concept and sexuality.